I'd like to present my case. A 50-year-old female residing in Tumkur who's completed her education till 10th standard and is a homemaker by occupation. She's a right-handed female and date of examination was 10th of November 2025 and the informant was the patient herself and the daughter. Patient presented with complaints of weakness in right upper limb since 6 months, history of thinning of right upper limb since 6 months, history of slurring of speech since 4 months, history of dysphagia since 4 months, and history of weakness in left upper limb since 3 months, and history of involuntary movements in bilateral upper limb since 3 months. A 50-year-old right-handed female with no comorbidities was apparently normal 6 months ago. When the patient noticed weakness in right upper limb in 6 months, it was not associated with pain. Patient initially noticed difficulty in mixing food, making bolus, and using her mobile phone and cutting vegetables, and also had difficulty in holding objects firmly. Patient also noticed difficulty in buttoning and unbuttoning at this point of time, but was able to lift the arm to reach the buttons. In a period of 1 month, patient noticed difficulty in reaching the buttons also and difficulty in combing her hair and reaching for higher objects. Patient was able to raise her arm initially, but had significant difficulty in raising it over the head. There was associated stiffness in the right upper limb. Patient noticed thinning of right upper limb, initially noticed dystory in the dorsum of the hand and palm, followed by forearm since 6 months. Patient noticed similar complaints in the left upper limb since 3 months, initially dystory, where patient had difficulty in holding objects, and then progressed to difficulty in raising arm overhead and reaching for the objects. Patient had history of difficulty in speaking since 4 months. Patient was able to read, repeat, and comprehend, but she noticed that she had to strain or increase the effort while speaking and was also associated with lisping. There was no history of nasal intonation of voice, no history of nasal regurgitation, no history of emotional incontinence, abnormal laughter, or crying. Patient had history of difficulty in swallowing food since 4 months, where patient initially had difficulty in swallowing liquids and then progressed to involve solids over a period of 1 month. Patient had difficulty in mixing the food in mouth and pushing the food to the back of the mouth, and there was associated choking sensation which was present, and the patient had to increase or strain while swallowing. Patient started eating semi-solid food to overcome this difficulty, but now currently patient has difficulty in swallowing semi-solid food also, ma'am. It was not associated with pain, no history of difficulty in chewing, closing the mouth while eating, no history of food getting stuck in the floor of the mouth, and no history of spillage of food while eating, and no history of nasal regurgitation of food. History of involuntary movements noticed initially in the forearm, right forearm and arm since 3 months, and also noticed later in the left forearm since 1 month. It was spontaneous, irregular, and painless, and later it was also noticed by the patient attenders and does not cause the movement of joint across it. There was history of unintentional weight loss, approximately 3 to 4 kgs in the last 2 months. There is no history of weakness in lower limbs, no sensory symptoms, ma'am, no difficulty in perception of hot and cold sensations, no tingling or paresthesias, no history of difficulty in lifting head in supine position, no history of difficulty in rolling over the bed or difficulty in breathing or nighttime awakenings, no history of cervical neck pain, shock-like sensations, no history of restriction of neck movements, no history of bowel and bladder disturbances, and no history of cramps, no history of diurnal variation of fatigability noticed. There was no memory disturbances or behavioral disturbances, no history of difficulty in perceiving smell, blurring of vision or diplopia, no history of difficulty in appreciating hot and cold water over the face, no history of deviation of angle of mouth, no history of difficulty in hearing, tinnitus or imbalance, no history of bowel and bladder disturbances, no history of dry skin, postural giddiness, palpitations and abnormal sweating. There was no history of fever, skin rash, dryness of mouth, oral ulcers or arthralgia, no history of recent vaccinations or exposure to toxins. Past history. Can I continue, ma'am?
Yes, yes.
No history of similar complaints in the past. There was no comorbidities and no history of TB or HIV in the past. Family history, she's a 50-year-old female. She's a P2L2 female, has 2 children, one male and one female, was born to a non-consanguineous marriage. There's history of coronary artery disease in father and history of GI cancer in mother, and she passed away at the age of 75 years, ma'am. Okay. Menstrual history, she's a P2L2, attained menopause 2 years ago, and there's no history of postmenopausal bleeding. Personal history, she consumes a mixed diet, bowel and bladder was normal, no addictive habits or exposure to chemicals.
Okay. So now we will analyze the symptoms. No?
Okay.
According to you, she is very well preserved person. No?
Yes, ma'am.
What was her occupation?
Ma'am, she was a homemaker, ma'am. She was not working.
Okay. So first thing she noticed, the whole illness is only 6 months.
Yes, ma'am. Only
It's
6
very
months.
rapidly progressive disorder.
Yes, ma'am.
And first thing she noticed was mixing food. That's what he told, no?
Yes, ma'am.
So for mixing the food, what all situations you find difficult in mixing the food?
When the patient is having
When
small.
you have to mix your food,
Yes, ma'am.
what you have to do?
We have,
You have to extend the interphalangeal joint.
And flex the proximal end.
Yes, and oppose the distal part of the fingers. So that is what happens, extending the interphalangeal joint, opposing the distal part of the fingers, and you do a movement. So what are all the muscles involved in extension of the fingers?
There is lumbricals
Interphalangeal joint.
and the extensor digitorum, extensor indicis, and the lumbricals.
Yes, mainly it is lumbricals with the synergist, the long muscles. So primarily it is a lumbricals that do, if it is only the fingers. And long muscles can act as synergist, agreed. Then when you have to oppose, what are all the muscles?
The distal
Opponent.
which causes the flexion of the distal joints like flexor, digitorum profundus, and superficialis.
Much more than that, you see what you tell is only mixing the food. So generally it is only the opponent's muscles and the lumbricals which are involved, unless it is a little more extensive lesion where you do other flexion of the terminal interphalangeal joint, all those things you don't. It's just oppose, no? So it is lumbricals and opponents. They are the primary muscles that are involved. So it could be, if it is an element problem, it could be due to involvement of the lumbricals and the opponents. Can it be human? Imagine a hemiplegia patient who is having right-sided weakness. Will he have difficulty in mixing food?
Yes, ma'am. The distal, like fine movements will be affected.
Upper motor neuron also will produce difficulty in mixing the food. And as you said correctly, it is the fine movements. So distal movements are fine movements. So in upper motor neuron, there is movement paralysis, but it is for fine movements. So these fine movements will go without weakness of the muscles. The limb will be stiff and the food might be clumsily mixed and go in between the fingers. So the mixing food difficulty, if somebody is noticing, you will think of these two conditions. Either your patient is having a problem of the lower motor neuron involving the lumbricals and opponents, or he has a problem with the kinetic melody due to involvement of the upper motor neuron. What is our patient's thing? You need more information. If the patient feels the limb is stiff, things like that. If it is not there, you don't know. So, and it is not associated with pain. So that means sensory symptoms are lacking. No?
Yes.
So if sensory symptoms are lacking in a patient with small muscle wasting, what are the things you can explore?
Starting, it could be UMN or LMN. In LMN, if sensory symptoms are not there, it can be the anterior horn cell or the motor root, or it can be the motor nerve only. And
So it is not due to ulnar nerve or CID1 root. See the small muscles, CID1 roots supply all the small muscles of the hand.
yes.
Whereas ulnar nerve supplies all the small muscles other than the thenar muscles. So it can be either, if the sensations are spared, one thing you can strongly exclude is it is not ulnar nerve, it is not CID1 root. Any other location you get small muscles, just as an exercise. Any other location you get small muscles weakness. So ulnar nerve, CID1 root, any other location?
Plexus.
Yeah, plexus, what situation it can produce?
Only the distal, if the lower plexus.
Lower plexus. Then what all points?
Anterior horn cell.
Yes.
Then
Lower plexus, what all points will be favoring if it is lower plexus?
Lower plexus, they will be predominantly that the muscles which are, they will follow the plexus pattern, whichever the roots that it is supplying, they are involved. It is the movement, which the muscle which is paralyzed, but the movement is not, can be still be done because it can be compensated by the other muscles.
So if it is lower plexus, it is mainly formed by the lower trunk, no?
Yes.
Lower plex found with lower trunk. Lower trunk muscles contain C8 and D1 innervated muscles. So always you have to say, so you see, you may know the case, but what we learn is not to miss an odd case. That is why we are looking like, analyzing like this. Sometimes 1 out of 1,000 case may be some other case. And when to diagnose MND in a young lady is where not at all the good diagnosis. So you will like to rule out other imitators. That is why you have to carefully look for. So supposing it's a lower trunk lesion, what is it otherwise called happening in children?
The clump case paralysis.
Yes, clump case paralysis. What will be the features? So sensory, motor, reflex, we tell.
Yes.
No? We thought about ulnar, we thought about CA-D1 root. Now we are thinking about lower trunk. So lower trunk means motor will be all the small muscles of the hand. And no forearm muscles, no proximal muscles. Sensation will be inner aspect of the forearm, inner aspect of the upper arm. Reflex, finger flexion reflexes will be absent. And usually, if it is very proximal, you can have a Horner syndrome. If it is close to the spinal cord, you can have a Horner syndrome. So that will be CA-D1 root. Little more inside, if you go, any other imitator is a syringomyelia. Very close imitator. Syringomyelias are many times mistaken as MND if you do not look for the sensations. So they exactly resemble. So small muscle wasting, always look for sensory symptoms and signs even if the patient is not telling. So if it is syringomyelia, what you will find?
They will have sensory symptoms, loss of hot and cold sensations, pain sensations over the trunk. They'll have distended.
By that time it involves the trunk and all, it will be very obvious.
There will
So
be
the early syringes, the point that will help is dissociated anesthesia. Because it is the crossing spinothalamic. So whereas in the ulnar nerve or CA-D1 root or in the lower trunk, it is all modalities of sensation. So what we tell is the key point. So if it is inside the cord, the key point is it is dissociated anesthesia. Reflexes will be absent. And you can have a Horner. So you can have a Horner if it is close to the spinal cord in the root level or if it is a syringe inside the cord. The point that differentiates both is dissociated anesthesia in syringe in the same segment and whereas in all other conditions it is all modes of sensation. Then you go to the anterior horn cell. So what will be the typical pattern in anterior horn cell disease?
They will have asymmetrical. Asymmetry with distal more than proximal. Movement paralysis can be there if it is involving the UMN also. And patient will have, if there is associated both UMN and element features can be present with weakness and wasting can be present. And it does not follow a nerve pattern or a plexus pattern. And the sensory is usually preserved.
So if it is anterior horn cell, it is not like this. So clear features are there which you should learn. So it will be a finger drop or cross-territorial clawing because it is motor unit. Motor unit is selection within a motor territory. Supposing C8, all the CA-D1 muscles are innervated at one stroke. It generally never happens. So this person, how it involved, we don't know. So we may have to, we need not fix a diagnosis. We will keep an open option. We may be able to help her. We don't know. No? So usually it's not a classical MND pattern. What the patient is presenting, whether it evolved a little more earlier and it was little different to start with, that we do not know. Depend on patient is telling. So usually the anterior horn cell pattern is, it is called sick motor neuron theory of McComas. McComas theory, it is motor unit that atrophies. So C8 segment means there are so many motor units. So within that only one motor unit will go. So there can be wasting or finger drop in one finger or one muscle. It will not be in the ulnar nerve distribution. It will not be in the median nerve distribution. It will be one finger. One finger is dropping. No? You are seeing, you are not seeing, no?
Yes, ma'am.
You are seeing. So one finger means like this. It will be one finger drop, no? Or you may have clawing, which is only one finger. Ulnar clawing will be 2.5 fingers. Median clawing will be like that. Instead, you get clawing of the ring finger or clawing of the little finger like that. That is anterior horn cell pattern. So, as you said, it is purely motor. And upper motor neuron, don't bother about that. There we have told it is kinetic melody. It is a different situation by itself. So these are the different levels. So you have to consider a person with a mixing food difficulty, whether it is from the nerve, ulnar nerve, whether it is from the CID1 root, whether it is the lower trunk of the brachial plexus, the syringomelia, or is it in the anterior horn cell? So all this you discuss under sensory, motor, reflex, and unique feature. So among understood means here the thenar muscles. And sensory impairment will be in the medial lower 2/3 of the forearm. There will be no corner, nothing else. Finger flexion reflex will be absent. That is ulnar nerve. Supposing it is CID1 root, so all the small muscles will be affected, and sensation will be medial part of the forearm, medial part of the upper arm, and you can have a Horner syndrome. And if it is lower trunk, if it is a trunk avulsion, like what you told Klumpke is an avulsion. If it is an avulsion injury, Horner's will be there. If it is a traction injury, Horner will not be there. All the small muscles go, and there will be involvement of sensation in the medial part of the upper arm and the forearm. And you go to the inside the cord, syringomelia, anterior horns. Syringomelia, you will have finger dissociated anesthesia in the muscles can be wasted depending on the degree of ulnar nerve or a median nerve territory. It will be one finger, something like that. So it's clear, no?
Yes.
These are the points. So we do not know what our patient is having. She is telling motor, but we will keep an eye open and look for all these things. You will do a thorough checking for Horner, sensation, everything.
Okay.
So that is the first thing that happened. And later what happened? She noticed difficulty in mixing food, making a bolus. And making a bolus means what? Next. It's a long
flexus.
So to make a bolus, small muscles are not sufficient. To mix a food, small muscles are enough. To make a bolus, you use the forearm muscles. And holding a mobile, that are forearm muscles. Cutting vegetables is opponents. And holding objects firmly is for long flexors. So from the initial involvement of the small muscles of the hand, now slowly the forearm flexors are getting involved. That is making bolus difficulty, cutting vegetables, holding a mobile phone. All this is long flexors. You told about some muscles. Would you like to tell them? You mentioned all those muscles which are flexing.
Yes. Flexing the distal interphalangeal joint is usually by flexor digitorum profundus. Superficialis will cause flexion of the proximal interphalangeal joint. And also the flexor digitorum, flexor pollicis longus and palmaris longus.
Palmaris longus, what does it do?
It causes cupping of the palm.
Yes. So it doesn't make flexion. So it's a cupping muscle. What is palmaris bruis? What does palmaris bruis do?
Palmaris bruis?
Palmaris longus is a cupping muscle. So it doesn't help to hold. What is palmaris bruis doing?
Palmaris bruis is like a vestigial muscle, but can maximum help.
What is the name applied for these vestigial muscles? Panniculus carnosus. Panniculus carnosus, because they arise and insert into skin. Other muscles have usually a bony origin and bony attachment, most of the muscles. And some of the muscles have attachment to the tendons, whereas this is from the skin to the skin. So they are called panniculus carnosus. So it produces wrinkles of the ulnar border of the skin. So it is so long flexors. You told profundus, superficialis, flexor pollicis long, flexor pollicis brevis, and these are the long flexors mainly. So those muscles are getting involved. Are they getting involved uniformly in all the fingers or selectively?
Involving
We'll say again, all the fingers. No?
yes, ma'am.
So if you take the various localization of these forearm flexors, what are the nerves roots? No?
The flexor digitorum superficialis is median nerve, C7, C8. Profundus, the medial to this one is supplied by ulnar nerve. The lateral half is supplied by the median nerve. Flexor pollicis, which is also C7, C8. Flexor pollicis longus is supplied by median nerve, which is that is anterior interosseous nerve, which is C8 predominantly.
So these muscles are supplied by different nerves, and it is supplied by different roots. So which root is supplying the flexors?
C7, C8.
It's C7, not much from C8. So is it from each one of these nerves, or is it from these roots, or is it from which cord? Forearm muscles.
Forearm muscles is from the lateral part of the anterior horn cell.
No, cord.
From
Plexus.
C.
It will be a combination of
medial cord
and
the extensors is from the posterior cord.
No, you're not extensor. We are only
Plexus is from the medial cord.
No. Is there what is the that is supplied in the forearm by the ulnar nerve, the median nerve, no? And at the level of the cord. Would you like any median?
Your voice is breaking.
What all muscles?
Ulnar nerve supplies the flexor carpi ulnaris.
The median nerve supplies.
Median nerve supplies the pronator teres and the superficial muscles of the forearm except the flexor carpi ulnaris. And deeper muscles through anterior interosseous nerve, it supplies the lateral half of flexor digitorum profundus and the flexor pollicis longus. And it supplies the thenar muscles. And the short head of flexor pollicis brevis also it supplies.
So would you like to consider median nerve and anterior interosseous branch of the median nerve?
Even the medial half of the fingers were also affected, ma'am. Like the digiti minimi and the ring finger also was affected. So
it is beyond the distribution of the median nerve. That's what you are wanting to tell.
Yes,
what is the peculiarity of anterior interosseous nerve? So this kind of cases, that is the exercise. It's a pure motor. Pure motor branch of the median nerve. So it will resemble an MND.
Yes. And the sensory.
The anterior interosseous nerve is affected.
Sensory will be spared.
And it only self-understood. No? If you tell pure motor, it means that it does not affect the sensation. So anterior interosseous nerve is a pure motor nerve. So it will resemble an MND. And it involves the forearm muscles innervated by the median nerve like flexor pollicis longus, flexor carpi radialis, no?
Flexor digitorum superficialis.
So that will be purely motor. It will be selected. It will not be involving the whole of flexors. So according to you, the whole of the flexors, what are the supply? What will be the point for C7 root? It has sensory.
C7 will have latissimus dorsi and serratus anterior also will be affected. So adduction will be affected. Triceps and anconeus is also affected. And even the extensors of the forearm will be affected along with the C7 is affected.
So C7 root will involve the wrist flexion and wrist extension.
And elbow
In our
extension.
case, it is only wrist flexion.
Yes, ma'am.
But at the level problem, so
Oh, ma'am, your voice is breaking.
the wrist, both flexors and will involve the, or what to do? Should I put like this? And I will switch off. Is it clear now?
Yes, ma'am. Now it is clear.
Is it clear now?
Yes, ma'am.
Not clear?
Yes, ma'am.
Is it clear? Okay. Flexors, wrist extensors. I am using this as an exercise for you are straightforward, but we will revise the neuron. Am I clear or not clear?
No, ma'am. Voice is still breaking.
In that you only. Yes, I have switched off the fan. Maybe there is some network problem because it's raining now. No?
Okay, ma'am.
Then you tell. What will
Yes.
be the features of C7?
C7, the wrist and extension both will be affected, and elbow extension will be affected, and shoulder adduction will be affected, ma'am, because of the serratus and the latissimus dorsi involvement.
What is the sensation?
Sensory will be usually the
Where is the sensation?
thumb and the forefinger, ma'am, on the palmar surface, and on the dorsal side, it can affect the medial 2.5 digits, sparing the nail beds.
No, C7 root will be only the middle finger. So C7 root sensation is middle finger. It doesn't involve the other fingers. You are mixing the median nerve and the C7 root. Now we are root, no?
Yes.
And C7 root is only the middle finger. And reflex will be jerk and
Triceps.
mainly the tricep jerk will go. So that is about C7 root. So your patient's wrist, so very unlikely to be a C7 root. He doesn't have any root pain. So whole of the forearm muscles have simultaneously become wasted, and flexion is weak means what other next level you think of a
can be more
peripheral neuropathy, short axonal neuropathies.
Yes.
There are some neuropathies which start in the upper limbs. They are called short axonal neuropathy. They can pick up all the nerves, median nerve. So I am dealing with the short axonal neuropathy. Because it is purely motor, I am dealing with the motor neuropathy. So those becomes possible when it is uniform. This pattern is not at all typical of the classical antecondylar pattern. If this history is correct, patient may not notice when the disease is evolving. So they may tell only when it has become very severe. So that is a possibility. But if it is true, you will have to think of a motor neuropathy as a more possibility. Short axonal motor neuropathies. Motor neuropathy with multifocal conduction blocks. They start in the upper limb only. They are not length dependent neuropathy. Am I audible?
Yes, ma'am.
So that you have to seriously think if it involves all the small muscles and all the forearm flexors together, that is not the typical anterior-console pattern. We will keep it in our mind. Just I am telling you, because once you diagnose MND, we are going to put the patient in the waste paper basket.
Yes.
So always give the choice of reversible condition. So that, and there are so many odd features, so that we should remember. So then patient also notice difficult in buttoning and unbuttoning. Okay. That buttoning and unbuttoning, what muscle?
Opponents.
Yes, opponents. So that we have already discussed. So it is some, as I always tell, hard signs, soft signs, and odd signs. In this patient, so far the hard feature is it is purely motor. And odd feature is Why it is picking up all the muscles simultaneously. So you have to keep your mind alert. Am I dealing with a treatable disease for my patient? That is very important. So that so whether am I dealing with a motor neuropathy with multifocal conduction block, they are more common in males. They start in the upper limb, but it is not 100% an male pattern disease. It can involve the females also, predominantly male, but it can affect the females also because there is symmetrical involvement of ulnar, median, all territories. So we have to, it's not like a root territory. So we'll keep that as a possibility at that level. So next thing you thought that she developed slurring of speech, no?
Yes, ma'am.
And you said that she has to strain.
Yes, ma'am. She had to put more effort while speaking, ma'am.
And there is lisping.
Yes.
From the history, she says, is there lisping component?
Yes, ma'am.
In
On
that
history.
case, like spastic speech.
Yes, it was a spastic speech, ma'am. There was no nasal intonation, or specifically the labials or like palatals were not affected.
No flaccid, no linguals involvement.
Like she was telling, like I asked her if she could, like if specific words were affected while she was speaking. She said like entirely the speech was affected and she could not point out to.
Okay, maybe we will keep that as a possibility.
Yes.
So if she, so there's some upper motor neuron component seems to come from the spastic speech. Okay, so spastic speech means bilateral upper motor neuron involvement is important. Unilateral upper motor neuron, you generally do it. Maybe she's having bilateral. When we examine, we are going to find some bilateral humans. We will consider that. Spastic speech is upper motor neuron. You get it in pseudobulbar palsy, multi-infarct syndromes, and sometimes craniovertebral junction anomalies, brainstem, when bulbar syndromes, you get that. So whether the person has got bilateral involvement, we'll have to examine and see. She has no nasal intonation, okay. No emotional incontinence. Okay, next one. So next is
difficulty in swallowing.
Okay. So swallowing, we always describe whether, because in this case, it is very important. Already there is small muscles, forearm muscles involved, whether the tongue is involved. So is there any oral phase problem?
Yes, oral phase
Is the food falling out through the mouth?
No, ma'am, she does not have any
If the
difficulty.
lingual
Only the lingual part is affected, ma'am, where she has difficulty.
Oral phase of the swallowing.
There is oral phase, there is pharyngeal phase, and there is esophageal phase, ma'am. In the oral phase, first we have to assess if the chewing of the food is affected, then it is usually the pterygoids which are affected. And if the patient is having spillage of food, then the orbicularis oculi. And if the patient is having food which is getting stuck in the gutters, then it is because of the buccinator weakness. And once the food comes onto the tongue, if there is lingual weakness or if there's spasticity, patient have difficulty in pushing the food backside towards the pharynx.
Does she have any of these problems?
She has difficulty in pushing the food backside, ma'am, like towards the pharynx.
There is oral phase problem.
Yes, ma'am.
Then is there a pharyngeal phase problem?
She told she has choking sensation while swallowing and she had to strain while swallowing, ma'am.
So if there is a choking sensation, definitely there is a pharyngeal phase.
Yes.
Then is there a stucking in the esophagus? No.
No.
So my patient has got a swallowing problem which involves both oral phase and pharyngeal phase. And you said that she has increased difficulty for liquids, no?
Yes, ma'am. Initially liquids, but now she's telling even solids also she's having difficulty.
So liquids need quick
Fine
coordination. So liquids get involved early in
UMN
type. So initially, if it was liquid, that's again going with the spastic speech. Probably she has got an upper motor neuron type of involvement of swallowing and speaking. Then no history of difficulty. Okay, next.
She had involuntary twitching movements, which was initially noticed in the forearm, and then the right arm, and then now since 1 month she's having those movements even in the left forearm. Which
She has
is-
herself noticed, huh?
Yes, ma'am. She and attenders both have noticed, ma'am.
So what are those twitching movements?
I thought it was
What
fasciculations.
all movements occur in muscles?
There can be fasciculations, myokymia, cramps, or contracture. Fibrillations can occur, but it is not visible to the naked eye. It can be seen only in the tongue. So
twitching is a fasciculation, no?
yes, ma'am.
So fasciculation, what do you understand by the term fasciculation?
Fasciculation is spontaneous contraction of a single motor unit, ma'am. Whenever the terminal axon is like detached from the cell body, there will be hepatic conduction of the axoplasm. So they will have spontaneous activation.
Very good. So this can happen in
In
neuron disease,
motor neuron disease,
motor
even
neuropathies also. It can happen in both. So how do you differentiate a benign fasciculation from pathological fasciculation?
benign fasciculations, it's usually subjective sensation, but will not be visibly there and usually occurs in normal muscles, which is not atrophied.
That's the most important problem. It will be visibly there in both conditions. But benign fasciculations, the muscle is normal. It is neither weak nor wasted.
And will be diffuse in case of pathological fasciculations, but will be localized in benign.
Yes, correct. Pathological fasciculations, patient may not be knowing. The examiner will have to point out. Whereas physiological, always patient comes and tells. Then, of course, there are electrophysiological differences. EMG, resting muscle activity, all different. As well as the clusters are larger clusters in benign and smaller clusters in pathological fasciculations. So that's okay. So she's having a fasciculation. How do you know it is myokymia? Because we are thinking whether it is a motor neuropathy with multifocal conduction block also.
Yes.
There you can get myokymia. So how does the myokymia look?
Myokymia will be shifting rapidly from one group of muscles to another group of muscles. They are vermiform.
So it's a vermiform movement. So it's a vermiform movement involving a larger bulk of muscles by activation of adjoining muscle fibers. It doesn't respect a motor unit. It is contiguous activation of adjoining muscle fibers. Acute denervation, it happens, especially Guillain-Barré syndrome, motor neuropathies. Those conditions, when they occur fast, it occurs. So it will be vermiform, it is understandable. What about her opposite upper limb? Is it affected?
Yes, ma'am. Even in the forearm,
Her
she has.
opposite upper
Yes.
limb. It started in the right upper limb.
And
Is the left upper limb
yes, ma'am. Since 1 month she has.
left upper limb is involved or not involved?
Involved, ma'am.
Okay. Is there any bladder bowel involvement, bladder bowel?
No sensory, no bowel bladder.
Okay. So at the end of your history, your patient has got a purely motor disorder. It is having a probably element involvement of small muscles of hands on both sides and forearm muscles right more than left, and probably a Neumann involvement of the speech, and probably a mixed involvement of oral and pharyngeal phase of swallowing.
She had.
So these are purely, tell ma.
She had stiffness also, ma'am, in right upper limb.
Okay. So she says that, huh?
Yes, ma'am. Like when using her phone and all, she felt her fingers were stiff.
Okay. And it is very rapid. Very rapid. Only 6 months, there is that much severe involvement. So it's a very rapidly progressive, purely a motor syndrome, probably involving significant element in the upper limb, as evidenced by fasciculations and wasting. And mild EMN, probably that stiffness, what is that? We will see the finger while holding the mobile stiffness may even be a small joint stiffness. We don't know. So usually stiffness becomes, early stiffness becomes symptomatic in the pronators. So they will feel that the forearm goes into pronated posture. Otherwise, small muscles, whether it is upper motor, we will keep it as an optional thing. And there is a spastic speech and there is a oral and pharyngeal phase swallowing without any pseudobulbar features. You said that there is no emotional ability, no kinds of pseudobulbar features. So at this point, such rapid progression. So what are possibilities go through your mind? As you said, if there is an LMN and UMN with fasciculation, you will consider anti-tonsil disease. I'm not saying no for that. LMN and UMN with fasciculation, anti-tonsil is a significant possibility, but very rapidly progressive.
Like
No
CV
pseudobulbar
junction.
features.
CV junction
And one
and
upper lip. Which one, ma?
CV junction
Tell me.
anomalous.
Oh, syringobulbous, syringomyelia, CV junction anomalies, no?
Yes.
And next, motor neuropathy with multifocal contraction block, with or without involvement of other cranial nerves, no? These are very important differential diagnosis because it is very rapidly progressive, only 6 months.
Yes.
So we will keep these things in our mind and we will examine the case. On examination, very good, you have written CV. That's, you have to very much remember that.
Yes.
So on examination, what are all the common manifestation of CV anomalies?
On examination, they can have a low hairline, abnormal neck length ratio. They can have papilledema, downbeat nystagmus.
They can present with lower cranial palsy
Lower
alone.
cranial palsy.
They can present with hydrocephalus. They can present with spastic quadriparesis. They can present like radiculopathies, cervical radiculopathies. They can present a pseudosyringomyelic presentation like small muscle wasting, bladder involvement. No?
Yes.
All these are the common manifestation. If there is a tonsillar herniation, you get an ataxia. Very good. You have read well, I think. Very nice. Go on.
On GP, her BMI was conscious oriented. She was well built and poorly nourished. BMI was 21 kgs per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Her pulse rate was 88 per minute, regular in rhythm, normal character. BP was 110/80 in right arm supine position. Respiratory rate was 18 cycles per minute, thoraco-abdominal. Temperature was 98.7 degree Fahrenheit. Neck length ratio was around 13 and she had a normal hairline, ma'am. She had a malar rash, ma'am, sparing the nasolabial folds. She's telling it is there since the last 15 to 20 years, ma'am. And there's generalized hyperpigmentation.
Is it a rash or is it a macule or a papule?
It is a rash, ma'am. Macular rash.
Macule. So
Yes,
don't call it as a rash.
Okay.
When you call rash, it's a raised one.
Okay.
Whereas macule is, so macular rash, there is nothing like that. You see, macule is one which is flushed with the skin.
Yes.
Papule is a raised one. So if it is a macule, commonly in this age group, you find something called pleiasma. Heard of pleiasma?
Yes, ma'am.
So perimenopausal age group, ladies get pigmentation of the face, that is called pleiasma. That's a macule, not a rash. It is not a papule. So if you find a rash with a raised erythematous, then you have to think of SLE or autoimmune diseases. Whereas this is there for so many years.
Yes.
It is not producing any other problem. So I feel it may be a chiasma.
Okay. She had wasting of thenar and hypothenar and flexor muscles of forearm.
What
Right.
is the generalized hyperpigmentation?
Like she's telling since the last 10 years, her skin color has become darkened. So
Whole skin.
whole skin. No.
Nothing like knuckle pigmentation.
No, ma'am. No.
So what situations the whole skin become dark?
Like in systemic sclerosis and all.
Yes. Very good. It is. It can be salt and pepper skin of systemic sclerosis or dermatomyositis. Dermatomyositis that can produce that. Any other condition? Very thin lady, cachectic, Addison's disease.
Addison's, yes.
So and then it can be a photosensitive skin lesions. Yes. That will be seen in the exposed parts, not generalized hyperpigmentation. So new onset generalized hyperpigmentation, you have to think of Addison's disease. And or if she is exposed to, she's not exposed, no?
No, ma'am.
Is it really hyperpigmentation also? You have to consider. Sometimes they will tell. So first possibility is Addison's, but A beetle generally produces knuckle
Oh.
pigmentation, but in one occasion, we published that case also. The whole person became so dark, so we never thought of beetle. This doesn't happen like that generally, but later his beetle was very low, and when it was corrected, he became like a Westerner. So nobody imagined that much fair person he was. For nearly 1.5 years, then he developed myelopathy, dementia. That patient was published. So when all these things came, he came to the hospital and he was so dark fully. So that's very unusual, not described in the literature. So we wrote up that case and he became like a European. So whether she's having a beetle deficiency, it is a rare possibility. Generally, it is a knuckle pigmentation. But sometimes people can become pigmented all over. Second, she's a thin lady losing weight.
Yes.
It can be Addisonian pigmentation. So, or sometimes it may be a constitutional hyperpigmentation which can happen with some kind of malnutrition also.
Yes.
What malnutrition produces this kind of pigmentation?
Niacin,
Yes, niacin produces pigmentation where?
usually in the anterior part of the neck and sun exposed areas.
And malar area.
Malar area.
Malar area. Otherwise, you get it in pellagra.
Yes.
Okay.
There's wasting of thenar and hypothenar and flexor muscles of forearm, ma'am, and bilateral complete clawing of hand was present. I have the picture.
All the 5 fingers are clawed, huh?
Yes, ma'am. I'll show the picture. Like,
is her clawing fixed clawing or correctable clawing?
like as long as I hold it, it will get fixed, ma'am. But once I remove my hand, it'll again claw.
Now, is it possible for you to mechanically extend from that clawing?
No.
What I want to know whether the small joints have become stiff or is it really a clawing?
If it is small joint stiffness, then it'll be very hard to manipulate.
So that's what I am asking. Are you able to? This is not a classical. You see, you get an extension of the interphalangeal joint and flexion of the interphalangeal joint and the extension of the metacarpophalangeal joint you get in clawing. Whereas in this patient, what it looks like, it looks that there is a posturing of the first interphalangeal joint in all the fingers. That's why I'm asking you, are you able to open the joint?
Yes,
Are
ma'am.
you able to stretch without pain? Is there any swelling? This doesn't look like a classical clawing. Any number of clawing you would have seen.
Yes.
Clawings will be like this. Extension of the metacarpophalangeal joint and flexion of the interphalangeal joint. She's not having any extension of the metacarpophalangeal joint. So it looks like the joints are stiff in the small joints of the hand. Apparently, I have not seen the patient. That's why I'm asking you whether extending the fingers is painful and restricted mechanically or not.
It was not painful, ma'am. Like there was extension of the metacarpophalangeal joint.
Anyway, this is not a classical clawing.
Yes.
Okay.
Then her higher mental function, she was conscious, oriented to time, place, and person. Language, she was able to comprehend and repeat, ma'am, but slurring of speech was there with syllables running into each other. Memory was intact. She was able to read and calculate. Because of the weakness, she was not able to write, ma'am, and no apraxia. Cranial nerve, olfactory nerve was normal. Optic nerve, visual acuity was 6/9 and 6/6 in the left side. Color vision was normal. Fundus was normal, ma'am. Third, fourth, and sixth cranial nerves were normal. Trigeminal, the sensations were normal. And jaw jerk was exaggerated, ma'am. Facial nerve and vestibulocochlear was normal. Vagus gag reflex was present, and there was no deviation of uvula. Spinal accessory, she was able to shrug her shoulder. She was not able to shrug her shoulders against resistance, but she was able to flex the neck against resistance, ma'am. In hypoglossal, there was restricted protrusion, and there were some indentations on the tongue. There was no deviation of the tongue. Tongue was spastic, ma'am, and there was wasting and fibrillations, which was noted.
Which is symmetrical.
Yes, ma'am.
Symmetrical
Then
wasting. 11 appears to be dominant. Is she, how did you know it is a spastic tongue?
like
How did you understand?
she had difficulty in protrusion of the tongue, ma'am, and it was not flabby. Like,
You palpated the tongue, huh?
yes, ma'am.
You have to hold a sterile gauze.
Gauze with a sterile gauze on.
And you palpated.
Yes, ma'am.
Then it looks spastic, huh?
Like I think.
Element component is very dominant now.
Yes, ma'am.
Increased grooves, fibrillation, which are bilateral, but they can have associated human involvement that you palpate with the gauze and see. Okay, if you have found it, it's okay. Then palatal movement.
Palatal movement was normal, ma'am. Like bulk, there was mild wasting, which was seen in the forearm predominantly in the right side compared to left side. And in right upper limb, there was increased tone where spasticity was noted, and the other limbs was normal, ma'am. Fasciculations were noted in the right arm and left forearm when I was examining. Bilateral thenar and hypothenar wasting and wasting of the forearm flexus, right more than left. And the clawing of the hand, I thought it was there. Right more than left, which is
you can understand it's not a typical clawing.
Yes.
You might have seen the typical clawing where there is a extension of the metacarpophalangeal joint. Okay, you can say that there is a deformity of the fingers involving all the fingers where the patient keeps the fingers flexed at the interphalangeal joint.
Yes.
That is the best way of describing, because it is not a classical clawing. Okay. Maybe the lumbricals are weak and so it became like that. And you find that here, what do you find? There is wasting in the anatomical snuff box, like the lumbricals. No, anatomical snuff box is here, little more posteriorly. So you find wasting of which muscle? The lumbricals. This muscle is what muscle? In between your thumb and the index finger, there is one muscle, no? That appears obviously wasted. What is that muscle? Extensor pollicis. You just don't hurry. Just think and tell. Between your thumb and the index finger, you are showing a muscle which is very much deep. What is that muscle? Intraossei, ma'am. Yes, that is what intraossei? The dorsal intraossei. That's the first dorsal intraossei. So it is not the pollicis or any other muscle. It is the first dorsal intraossei. So that in the first interdigital web space is produced by the first dorsal intraossei. So first dorsal intraossei muscle is very much wasted. That area has become a depression. And other intraossei are also probably wasted because the grooves are prominent. But this one is very, very prominent, the first dorsal intraossei. Okay, go on. Then? Neck flexion, she was able to do, it was 5/5. Shoulder flexion was 4-. Against mild resistance, she was able to do. And in the right side, extension was 5/5. Adduction was 5/5. Abduction was 3/5 on both the sides. Internal rotation and external rotation was 4/5 on the right side, ma'am. Elbow flexion and extension was 3 in the right side and 4- in the left side. Pronation was 3/5 in the right side and 4- in the left side. Wrist flexion and extension was also 3/5. Hand grip was weak on both the sides, ma'am. And small muscles of the hand, the extensor carpi radialis longus was 4- and carpi ulnaris was also 4-. Superficialis and profundus, the distal flexion of the interphalangeal and the proximal flexion was 2/5. Flexor pollicis longus was 3/5. Flexor carpi radialis was 4-. Abductor pollicis and extensor pollicis was 3/5. The small muscles of the hand, I didn't know how to grade them, ma'am. No, small muscles you need not grade. Okay. Whether they are weak or not, that much is enough. Nobody grades the small muscles. Okay. The small muscles of the hand, both the thenar and the hypothenar muscles were weak, ma'am. Lumbricals, all the 4 lumbricals were weak. Even the palmar and the dorsal intraossei was weak, ma'am. Lower limb muscles power was normal, ma'am, 5/5 in all the groups. Sensory examination was normal. Reflexes, superficial reflexes were present. Jaw jerk was exaggerated.
Abdominal superficial reflex was absent. Deep was also absent, ma'am. Cremastic was present, and plantar, it was plantar flexion. Reflexes, biceps was 3+ on the right side and 3+ on the left side. Triceps was also 3+ on the right side. Supinator jerk was also 3+. And then finger flexion was 2+, ma'am. Knee jerk was 3+, ma'am. Even though there was no weakness or tone increase, jerk was 3+, both in the right and the lower limb. There was no clonus. Hoffman's reflex was positive. She had that snout reflex and palmomental reflex, ma'am. When on going near the corner of the mouth, it was active.
So after plantar?
Plantar was flexor, plantar flexor.
So after examination, what are all the positive? It's again, it is purely motor only, no?
Yes.
Then what are the features you are finding?
The other gait.
Significantly, you find release reflexes.
Yes, ma'am.
So that means the level is much higher.
Yes.
You told that the snout reflex. What
Yes.
are the reflex?
Palmomental reflex was positive. Glebular tap was negative.
Palmomental is positive on one side or both sides?
Only right side, ma'am.
Only right side.
Yes, ma'am.
So asymmetrical palmomental is more relevant than symmetrical palmomental.
Yes.
Because the palmomental is positive on both sides, it may not be that relevant. When it is asymmetrically, it is relevant. So what is the pathomechanism of palmomental reflex, you know?
Usually as the UMN, as the central nervous system matures, these reflexes are usually inhibited from the frontal lobe. But once once this is affected, they'll be released from the cortical inhibition.
So these reflexes happen in frontal lobe involvement.
Frontal lobe.
So what is the relation between palm and chin? Palmomental means when you scratch the palm,
yes,
the mentalis contracts. Yes. So how are they related?
Not sure.
You see, in intrauterine life, the child keeps the palm to the chin in normal position, a normal lie. If the child is having a normal lie, it is a left occipital posterior with the palm approximated to the chin. You know that. Yes. You just finished your MBBS and your postgraduate, so you will be remembering it better. So to keep the palm to the chin, it's like this, no? Why is the palm kept to the chin? For the sucking. No. Intrauterine, what sucking? No, it is to reduce the space. If the child is keeping one hand extended away from the chin and one leg extended and all, so much space will be needed. So the child is folded in such a way so that the space to accommodate the child in the uterus is very less. So the child is lying down with the left occipital posterior position, neck flexed and palm in the chin. You know that, no? Yes. So to keep the palm to the chin, there is a palm chin center in intrauterine life. That is in the parietal lobe. And within 30 days of birth, this palm chin center becomes suppressed by frontal lobe demyelination, frontal lobe myelination. But some people it can persist. So bilaterally present palmomental reflex without any other release reflex is not significant. But if it is unilateral, it is significant. That indicates that the fronto-bulbar connection on the left side is affected. So the right palm chin center is released. So the person slowly goes into the universal flexion posture, that the reflex adaptation, that is the palm chin reflex becomes positive. Then you said that there is jaw jerk brisk. That means what? Usually the lesion is above the trigeminal nucleus. So from the cortex to the pathway to the trigeminal nucleus, where is the trigeminal nucleus? In the pons. Pons. So there is evidence to say that there is failure of inhibition of the palm chin center on the parietal lobe by the frontal lobe. So there is some degree of involvement of the frontal lobe. Second, the jaw jerk is brisk, indicating that there is a cortico-bulbar disconnection at the level of the pons or above the pons. Then third, you said that there is quadriparesis like bilateral exaggerated reflexes in all four limbs.
Yes.
So there is bilateral corticospinal tract involvement. So there is frontal cortex, brainstem above the pontine nucleus, and bilateral corticospinal tract involvement. In addition, you are having an element involvement of the hypoglossal nucleus.
Yes.
An element involvement of C7, C8, D1, more on the right side. So this is the involvement, and it is all very rapidly progressive. And this is very, very unusual for a classical androcortical disease. So this, if this has happened over 1 year or 3 years, so this much extensive from the frontal. So this kind of extensive involvement of the motor structures is described with what condition? You see, you have got androcortical, of course, but you should be very cautious. This may be something else. Because classically, you have the superoxide dismutase, and you have got so many other genes involved, alsin, no?
Tenataxin.
But TDP43 can be this much extensive.
Okay.
Because TDP43 can involve the frontal cortex, basal ganglia, corticospinal tract. So whether you are dealing with the TDP43 syndrome, so extensive involvement is there. But that will not happen in 6 months. So either the person has not observed early symptoms, or are you dealing with a rapidly progressive syndrome involving all these tracts? Some tractopathy other than MND that you will have to consider as a strong possibility. Or is it a paraneoplastic syndrome? Some late onset leukodystrophies, no? Where only motor symptoms will be there. Because spasticity and all is so much significant, and element is very less. So it's a purely motor syndrome, agreed. EMN and element, very extensive from the frontal cortex to the brainstem to the corticospinal tract. So is it a late onset type of leukodystrophy, where sometimes you can have element also? Or is it a TDP43 type of motor system degeneration? Or is it a paraneoplastic syndrome?
Can it be that group of syndromes that they'll have frontotemporal dementia with ALS, ma'am? Can it be that FTD ALS group?
It can be, but so fast. That's what TDP43 I told.
Okay.
FTD ALS belongs to the TDP43 group, but why is she so rapidly progressive? So you did the imaging, huh?
MRI is normal, ma'am, spine and brain.
So of course, I am telling that it may finally be a rapidly progressive androcortical disease in a relatively young woman. Then you will have to look for paraneoplastic syndromes.
Yes.
Whether there's an acute neoplasm or heavy metal poisoning, metal toxicity, like manganese, mercury.
Yes.
So are you dealing with the metal toxicity, or is it a paraneoplastic syndrome? You should have to look for, but if the MRI is normal,
yes, ma'am,
you have to pick it up. So this is very rapid. If I believe her history to be correct, it is very extensive from the frontal to the brainstem to the spinal cord and antecortical and bulbar cranial nerve nuclei. And in a short span of 6 months, she has become totally disabled. So we will think of non-degenerative causes like late onset leukodystrophies, which can be acquired also. That you will keep in your mind. Second, paraneoplastic syndrome, metal toxicities. If all this is ruled out, it is going to be a unusual case of rapidly progressive motor system disease. Is it going to evolve into a TDP43? Because already there is a frontal release reflex.
Yes.
So it's not a straightforward case of MND. You should carefully observe that this is more extensive, very rapid. So you will evaluate. You have already done it. You said MR is normal.
Yes.
And you will have to give a very guarded prognosis to the patient. And carefully look for metal exposure toxicities. If it is not there, it may be TDP 43.
Okay.
That's what. Anyway, it's a good case. And I revised the nerves and the root pattern grossly, because that is what is important for us. And you should know that this kind of symmetrical involvement is very uncommon. And you showed that hand, no? That hand is not a clawed hand.
Okay.
It's probably a spastic fingers.
Okay.
Because of the increased tone, you said that the person feels the fingers are spastic. So the increased tone in the fingers may be making her posture like that. It's not a clawing. So that is one learning point. It's not a clawing. So that may be the expression of the upper motor neuron involvement. Spinal cord also done, imaging.
Yes, ma'am. Spinal cord also normal.
Everything is normal.
Yes, ma'am.
So
autoimmune profile was also normal, ma'am.
Okay. So it may be TDP 43, but you will have to exclude other causes which may have some treatment options. If you have excluded metals, that is metals,
Yes.
that is the only thing which you can treat, and paraneoplastic. If you find a paraneoplastic antibody, one thing you can, if you treat the neoplasm, it can get arrested and the antibody can be removed by plasmapheresis. No? So those are the options. It was very rapid, you have to pick up that. And as an exercise, differentiate the different patterns. Anyway, nice, you presented very well. And we should not tell nice case, my teacher has told her. Because she is a young lady of 50 years.
Yes.
50 years is not young. You know, I am a retired person. So she's only 50. She is a very, very young lady and very rapidly progressive disease. So we should always give her the option of treatable disease. How you give? By carefully picking up the odd features. So there were so many odd features. There was so much of non-selective involvement. It's not a motor neuron disease pattern. So, and very rapid progression. So if it is possible, you do a paraneoplastic antibody.
It was negative, ma'am.
Negative.
Negative.
In that case, she is an unfortunate lady. So you have to exclude all these things, because even if you screen 1,000 patients, and if one patient shows a treatable cause, it is worth it. So if you have done it, it is good. But all these atypical features you have to pick up.
Okay.
So good, nice.
Thank you.
Okay. Any doubt is there?
Can you explain that emotional incontinence in pseudobulbar and...
See, emotional incontinence in pseudobulbar in degenerative versus vascular. It can happen in both the vascular syndromes and degenerative syndromes. Multi-infarct syndrome, it can happen. Multi-infarcts are non-selective, vascular. Whereas degenerations are selective, they involve only the motor fibers. So in degenerative conditions, the emotional ability can be very late. Whereas in vascular pseudobulbar palsy, emotional ability is very early. Multi-infarct patients will be crying too much and laughing too much. Whereas degenerative type of pseudobulbar, just like you told, brisk jerks will be there, but emotional incontinence or emotional ability may not be obvious. That's the thing. So because it is selective.
Yes.
Degeneration is selective. Vascular is non-selective.
Okay.
Any other question?
No.
Only thing in this case, you should find out the territory is long beyond the spinal cord or endocondylar. It has gone to the frontal lobe and very rapid. So you will keep your options open, and you will not be surprised if some tumors or something makes their presence suddenly. She has so much of pigmentation. Is it a paraneoplastic manifestation? We do not know. Paraneoplastic also, patient can become pigmented, no?
Yes, ma'am.
So whether that pigmentation is paraneoplastic? Yes. So we will still keep our option open. even though it is all negative, you will just keep the patient under follow-up and keep reassessing periodically, provided that person escapes any complications due to chronic aspiration. Okay.
Is
Now,
there a role for starting riluzole and all in these patients, ma'am?
because we have nothing else. We have nothing else. So we always give riluzole, especially riluzole is given only for patients with this kind of bulbar, pseudobulbar involvement who are next to going to land with respiratory paralysis. So riluzole is an anti-excitotoxin, which is believed to postpone the ventilatory stage by few months. So it is not working on the other kinds of degeneration. It works on the respiratory. So we will watch for, we will give, whether it helps or not. At least if you give her nothing, she will be psychologically shattered. You will keep her under follow-up for looking for a malignancy. And you should give riluzole, and you should give something to reduce her spasticity. The fingers are more spastic rather than clawed. So small dose of baclofen you can give and improve her nutrition and keep her under follow-up. Because that pigmentation, weight loss, rapid progression, still the paraneoplasm. We have seen such patients, and sometimes we have picked up the neoplasm 2 to 3 years later. Because if you take NIMHANS and all, patients come for follow-up to the same institute for several times. Otherwise, they go to another institute, means you will lose them. So, because generally in NIMHANS and all, they come to the same institution again and again. We have picked up secondary deposits 2 to 3 years later also. So it's a very much possibility. You said that she became pigmented, she lost weight, and the disease is rapidly progressive. Paraneoplastic is a strong possibility.
Okay.
So good. Thank you. Nice presentation.
Thank you, ma'am.
You did well for an MD student. Wonderful. Keep it up, because for a doctor, it's hard work. I always tell that people keep their most valuable possession, that is their life, in your hand. Yesteryears, long back, when my grandparents were there, they used to tell that doctor's fees used to be given in a betel leaf with a silver cloth, the silk cloth. My grandparents. Now patients will hit us, cut our neck, all those things. The times have changed, no? But it is up to us to keep up our divinity of the profession. Because in between, some of our own colleagues would have destroyed the sanctity of this profession. I think so. Among medical people also, a small percentage is a general population. Some of them might have been materialistic, and somewhere the reputation was lost. So building up the reputation depends on commitment, care, and respecting your own qualification by your own self. Whatever maybe the people are doing. In Karnataka, it is very much less. In Kerala, every alternate day, they cut the head of the doctor. You see, but still, be yourself. It's a divine profession. You have read very well. Nice, very nice. Thank you.
Thank you, ma'am, for the opportunity and teaching.
Shall we?